We're here to talk about emergent opening of the chest in the ICU setting. It's something that happens very rarely, so I think in general it's probably going to be about less than 1% of the time. So we should be doing this at the most once, maybe twice a year at the most. Often, it really shouldn't be more than that, but because it's such an infrequent event, that's why we need to actually drill this, right? Because when it happens, it really is urgent. And if nobody knows what they're doing, then it's going to take more time, and time is really of the essence when we're trying to open the chest. So ideally, we can identify patients that need their chest opened prior to them crashing in the OR. In the ICU, and then we can get them down to the OR. But as you've experienced, the process of getting a patient downstairs is actually, it takes pretty long. We call the OR, blah, blah, anesthesia comes up, blah, blah, blah. It may be 45 minutes actually before we can get a patient downstairs. And we sometimes just don't have the time, or patients really just suddenly crash, right? So if you've talked about this, generally there's 3 reasons to open the chest, right? And somebody can tell me those 3 reasons.
This is a quiz.
Just very generally.
Yeah.
There's 3 reasons to open the chest in a post-op heart. And
well, I know the word you don't like, but it's tamponade.
Tamponade is very easy, right? Tamponade is probably the best reason to open, because as soon as you open and the blood gushes out, then the patient's absolutely fine, right? So that's one reason. The second reason is kind of related, is to control bleeding. Okay, so what can happen is that the patient gets very, very hypertensive, something breaks, tears, and it starts bleeding, and all of a sudden you lose their blood pressure and the patient tamponades. So you open the patient up, oh, here's something that's bleeding, you put a finger on it or you put a stitch in it, and problem solved. Okay, so that's the second reason. The third reason, which is usually the worst reason, is open cardiac massage, right? So we can do much better cardiopulmonary resuscitation if we have the chest open with the heart in our hands, or we can inject direct epinephrine intracardiac and things like that. But usually that's a pretty futile situation. So those really are the 3 main reasons we open the chest. There's not anything else. Again, ideally we'd like to do this downstairs, but sometimes we don't have the luxury of doing that. So when a patient crashes, hopefully one of us is here. Sometimes we're not, or we're somewhere else. So there is this kind of myth about, oh, you can't do CPR on a patient who's had cardiac surgery. That's not true. You should. I mean, if it means the patient doesn't have a blood pressure, right, do CPR, and nobody's going to fault you for doing that. But you also have to remember that you have other tools that like if a patient goes upstairs on the floor, it's a little different. In the ICU, you have full monitoring, but you also have pacemakers, right? So that's always a thought. Should we defibrillate, and can we pace? That's usually the first steps. Okay, if the patient's fibrillating, you got to defibrillate. But after that, you should be able to pace, because you got pacing wires, unless they've been taken out. But usually they still have pacing wires. So those are some of the first steps. But hopefully we're here and we identify a patient that looks like they're going to crump, and then we'll say, okay, we got to open the chest. So the drill should be about, okay, what do we need to do to get the patient ready and the chest open? I really think that we should be able to do that in about 3 minutes, okay? Probably no more. I mean, in 3 minutes you think is maybe a long time, maybe not a long time. I personally think if we can get it below 30 minutes it'd be better, but realistically it's probably about 2 or 3 minutes. Meanwhile, CPR should be performed. Whoever's there who's performing CPR, it's the same as a normal code. But then the people around that person need to get ready. So generally speaking, I think you need at the minimum 4 people. Okay, there's probably going to be a lot more, because when we call code in the unit, everybody comes and there's a lot of help. So it is true that in the very early stages, the more the merrier, because there's a lot of things that need to happen simultaneously. But at some point, there's going to be too many people. Just like any other code, once things are kind of progressing, then we actually need people to clear out so that there's better communication and ease of things going in and out of the room. So once the patient's coding, your job, most likely, if it's your patient, is to continue to take care of the patient, okay? We don't want you to be the one to be running out and preparing the card and blah, 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 blah. No, you should continue to take care of the patient, whether that means increasing your drips, making sure they're ventilating, whatever you're doing, continue to take care of the patient. Everything else should be happening around you, okay? So that's the first person, is the actual nurse taking care of the patient. You need an assistant. You may say, okay, I need more epi, I need this, I need that. You need somebody that's gonna go get things for you or help you do things. So that's the second person. And then my part is the surgeon, and then I need an assistant of some sort. Sometimes the OR can bring somebody up, sometimes it's a PA that's here. So those are the 4 key people. Now, again, you can start adding in, we need respiratory therapy, blah, 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 blah. Again, the more the merrier at first, but eventually we're gonna really need maybe 4, 5, maybe 6 people. That's all we should need. So as soon as the surgeon says, okay, we're gonna open the chest, the ICU desk or whoever's around should call the operating room immediately and say, okay, we're opening the chest, which should prompt 2 things. One, the OR should respond by sending somebody up here. Okay, if they have a tech or somebody available, they should send that person up. Ideally, if they can send an anesthesiologist up, that'd be great, okay? 2, they should start opening up a cardiac room, okay, and that takes some time. But so that phone call needs to happen right away, and those 2 things need to happen. Next, we need to prepare the room, okay? So if you think of what we need to do, we're gonna need a lot of room, so a lot of stuff needs to get cleared out. What I always think is that the table actually needs to be moved towards the center of the room, because somebody may need to be at the head and somebody's gonna need to be on both sides. So the bed needs to be moved, okay? And then a big roll needs to be shoved underneath the patient's chest here, because we need the patient cord like this, not like this, okay? Because the air beds are kind of cushioned, so they're generally kind of crumped in like this. We want their chest exposed, so we can kind of talk about it. And I'd be willing to, like, if you want to assign roles to certain people, that's fine, that'd be great, in fact. I don't want to tell you who does what, but all I'm saying is these are the goals. Yeah, the chest needs to be exposed, meaning this needs to be ripped off. A roll needs to be placed here. We should get defibrillator pads on the patient. We were talking about Bovie pads. That can happen, but it's not a priority. At some point it might be, but early on that's not what we need. We need the patient prepped, and while that's happening, the surgeon and the assistant will be probably gowning, opening up the instruments, and trying to get ready to drape. So those 2 things need to happen simultaneously. The surgeon is going to dress and get ready to drape, but somebody needs to get the patient prepped. That means moving the table out, exposing the chest, putting a roll behind, getting defib pads on, and just prepping. And prepping could be anything, betadine, chloroprep, it doesn't really matter. Again, speed is of the essence, okay?
Can I ask you a question
Yes.
about that? Because we did a teacher iodine here. That was determined not adequate enough. Now we went to the chloroprep stick sponges, and then you brought in the these
scrubs.
What
Yeah.
do you prefer?
I think chloroprep would be fine.
Well, they're
Chloroprep.
both chloroprep.
No, they're not.
Well,
One is Hibiclin.
Hibiclin,
One
yeah.
is for
Which is
scrubbing.
Yeah.
And
yeah.
another
So,
one.
but
Has an
Yeah,
alcohol.
so
and
this I would use actually to wash my hands.
Right.
This I would use to prep the patient. And basically, when we say prep the patient, it's from the neck maybe down to about here. That's all we
Okay.
need. Okay, but basically the chest tube sites, the pacing wire sites should be all prepped in, and then a big roll, and then we'll get the drapes open. And I think we went through in the cart. There should be numbered bags for the instruments that we need. I don't think you guys need to get too involved in that. We'll open what we need, and we'll get set up.
because we've all told the nurses that the trays would be open,
Yeah.
but you're responsible for
Yeah,
the instruments.
Generally, yeah, we're responsible for the instruments. Hopefully somebody from the OR who knows what the instruments are is gonna start handing things up. So, what stands in between me and inside here? It's pretty much skin, right? Fat and muscle and the bone, right? And it's already been opened. So it really does not take long to get into a chest. Basically, you just take a knife and you swipe down all the sutures, just break, and then we just find the wires that we put in. There's usually 6 or 7, and we'll just cut those, and then it's just as open. Okay, so that part really takes about 20 seconds to do. It's up to there that actually takes a longer. So, you know, getting the patient prepped in position, blah, 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 blah. And that's why I think 3 minutes is realistic, but if we can get it shorter, that's better. Okay. And of course, you have to imagine all this is happening while CPR is being performed. It's a very chaotic situation. So that's basically the gist of it. If anybody has been through 1 or 2 of these, it's probably a little more easy to relate to. But it's not very difficult either. It's just that, you know, it has to be done very, very efficiently. And so I don't know. I mean, if we can be very rigid and assign specific roles to everybody, but the problem will be, you know, if you're in role A, B, or C, or D, and one day you're A and the next day you're C, you may not really remember. So I think it's kind of generally better that everybody knows what the goals are, so that, you know, everybody could, as a team, get the patient ready in the shortest amount of time. I don't know.
No,
I'll
that's
ask your
true.
feedback on that. Would you rather have like roles, as in I'm responsible for doing this, this, and this, and the next person is this, this, and this, or would you rather have, okay, there's no specific roles, but we know what the goals are?
Usually somebody who's in charge, the charge nurse usually assigned.
Assigned.
That's why
Yeah.
like,
Yeah.
a couple of times he did it, that's what happened.
The 3 times, I've been there for just 3 times. 1 on day shift and 2 on nights, actually, for late surgeries. And we usually try to assign someone because it is so hectic. And one of the reasons I really wanted Cheryl to make sure we looked through the cart, I needed her permission, so she technically owns that cart.
No, I don't. What happened was the surgical group gave us a list of what they wanted on the cart, and we basically followed it.
I
Again, they had
know.
certain brand names that we couldn't do. You know, like we're Sutter, so, I mean, a 4x4 is gonna
Yeah.
change to
Yeah.
whatever.
She knows I'm joking with her, but she does technically kind of own this cart, I feel. So she's the one who
We shouldn't
puts
say that.
everything in the cart. But I feel like
Good.
that was one of the hard parts, is because a lot of us we learned about open chest. We just didn't know, like even with, I had to put a saw together. This was more fancy, but I had seen it, but you know, you have to open it, you have to put the parts together.
All
Yeah.
the instrumentation stuff, I think we can take care of.
Yeah. Well, that's good.
From your
because-
part, you know, it's just like, you know, you have to learn how, you have to
Yeah.
know how to use your own defibrillator, right? Because
Yeah.
everyone's
Right.
a little different.
Right.
So
Yeah.
you should be familiar with at least where the cart is, and
Yep.
where, you know, at least what
Yeah.
things are in what.
Yeah,
you know?
exactly.
That's
Where
all you really need to
things are.
know. Most of the time, we're gonna open up everything anyway.
Yeah.
But as I said, if you are the primary nurse for the patient, don't worry about all this. Just continue to take care of the patient. That's the sole focus. Don't be distracted. You know, you're going to still have to manage the drips and things like that, and then the rest of the people will try to work around you. But again, you need help to prepare the room. It really takes time. I mean, you know, the bed needs to be moved. That headboard thing needs to get moved out of the way. The patient, you know, needs to be moved down. We have to put this behind, tear everything off, and start prepping, right? So, you know,
Yeah.
people need to know.
And it starts with the room prep would before the patient comes,
Yes.
making sure that you've got everything in its place and it's
Yeah.
organized and no clutter.
Yeah.
I just cannot stress that enough.
Yeah, lights, you know,
Yeah.
better lighting,
Yeah.
all these things.
Yeah.
It takes time to, so again, that's where we can like drill and get it down. And then the rest of the surgical part, you know, we'll try to take care of. You know, obviously, we'll call for certain things. Usually the main thing is suction. We'll need some sterile suction, and it should all be in here.
It is.
And
It
it's the
is.
same contraptions that you're using for NG tubes and things like that. But that's probably the only thing that we'll really call for. Irrigation should be in here too, right? Some bottles
That,
of saline, so.
I wanted to ask you about that. Okay, so yes, we have saline and betadine in there.
And you have warm saline too, right?
Okay, that was my question. I have gotten warm saline. I mean, there's been a few times when I've gone ahead and thank God we have that quick little warmer for the peritoneal dialysis stuff. So when I kind of thought things were going to hit the fan here, I would put the saline on that. The other thing is that we have warm saline in our pharmacy. So do you want us to be prepared for warm saline absolutely every single time? 'Cause
I mean, it's better to have it, but
Uh-huh.
it's not like critical. Basically,
Yeah.
it's gonna be used to irrigate out all this clot.
Mhm.
So, if it's not warm, it's not the end of the world, of course.
Right, we've
But-
done probably, I'll tell you now, we probably have only done about 20% of them have been warmed, and the rest have all been room temperature saline.
Okay.
But that's one of the things, that was one of my questions for you, because we can institute something here, there's.
Well, it's probably
there's-
too infrequent to, keep
Well-
unless you're using warm saline for something else, I
No,
can't
it is,
imagine.
it is available. Pharmacy's not that far away. I mean, we
Wow.
can do,
So-
but we can do 500 cc's or a liter on our peritoneal dialysis warmer. That will warm in about 10 minutes. So, like, let's say you've got a patient that's really unstable in the unit, and that's a potential. That should be something that the charge nurse, the bedside nurse, break nurse is looking at and instituting.
Mhm.
Because we can do that.
Mhm.
I'm saying we can do that. I know we can do that. Okay?
So,
Because we've done it in the past.
Mm. Yes.
I have a question. So, we're gonna be good at prepping everything, but sometimes happen in nights when you
Mhm.
guys are not here.
Yes.
It has happened in the past that we call the code,
Mhm.
and sometimes the ER doctor or the
Yeah.
hospital, they don't
Yeah.
feel comfortable. So my only question is,
Mm.
I know that you are, have been emphasizing about the pacer, but we should be using the ACLS in this codes.
It's a little different.
Okay.
Yeah,
Uh-huh.
ACLS is a little
Good
different in the
question.
post-op part. First of all, nobody should be opening the chest except for the surgeon, okay?
Mhm.
No matter what, really, if they're not a trained cardiothoracic surgeon, they probably shouldn't be opening the chest, even if it's a physician. Because things can happen, you can actually make things worse. So until somebody with that expertise arrives, I would do standard CPR and resuscitation maneuvers. So just that point. The second point is, yeah, ACLS is a bit different. You have to understand the setting. ACLS is more for patients, medical patients that code on the floor or outside the hospital. A patient that has had heart surgery is entirely different. The dosages of medicines that we should be giving are usually different. And the reason is they've got holes in their heart. Okay, so giving a whole milligram of epinephrine is just too much, because if the blood pressure goes to 220, they're just going to blow a hole somewhere. So it's often not necessary, and the most that we sometimes will use 100 mics, 200 mics, maybe 500 mics at a time. So I would not, but if we're not here, you do what you do, and you do what you're comfortable with. But just remember that they're different, and you have more instruments at your disposal, because again, you have pacers, and your drips are all hooked up, right? I mean, you're in a different situation than if you're on the floor or outside the hospital. So it should be you have more information, you have more tools, so it should be more methodical than a super chaotic situation. Yeah, I generally, when we get that call in the middle of the night, yeah, the first thing we always want you to remember is that you have a pacer, right? So it's actually pretty important to get an accurate assessment of the rhythm, because you can't pace somebody who's in ventricular fibrillation. It looks like you're pacing, but you're not. Underneath there's VFib and the pacing spikes, and you think, oh, great, we're pacing. No, you're not. The heart's not doing anything. So yes, you need to stop doing CPR so you actually see a ventricular fibrillation waveform. Do ACLS to treat that VFib. But once you're out of it, then you should start pacing immediately, right? Because usually the heart will capture, and then you'll have a stable rhythm. Fibrillating it, same thing, just do the same drill, okay?
ACLS for that VFib requires 1 milligram.
Yeah, so I would.
You should be thinking about half.
Yeah, I would say at
Okay.
most half,
Okay.
right? Just go a little easy. And of course, if it's dire stress and you've been doing it for 20 minutes and you haven't gotten the patient back, of course, we're probably going to escalate the dose of epi. But generally speaking, if we're here and the patient's blood pressure's really low, we very rarely give a milligram. It's a lot happy.
Mhm.
You're using
Apparently
mic